Hello, everyone. My name is Tiffany Dangleben. We are pleased that you all can join us for this week's lecture in Volume 3 of our No Neuroanatomy Didactic Series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuro Board, as well as members of the No Neuropsychology Committee. We would like to thank our 2023 sponsors for their generous financial support of this series. Additionally, we are grateful to our Society of Clinical Neuropsychology colleagues for their sponsorship and wanted to share information about their upcoming convention programming at APA in Washington, D.C. This will include 7 invited speakers, 9 symposia, 3 scientific poster sessions, a SCN presidential address, and member town hall meeting. Registration for APA 2023 is now open. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and recording of today's lecture will be provided on our website and YouTube channel later this week. Now, it is my pleasure to introduce Dr. Erica Cotton for today's lecture titled Basal Ganglia and Associated Disorders. Dr. Cotton is a board-certified clinical neuropsychologist. She holds dual appointments in the departments of psychiatry and neurology at Northwestern University. She specializes in epilepsy, movement disorders, and functional neurologic disorders. Dr. Cotton, take it away.
I'm Erica Cotton. I appreciate being invited here by No Neuropsychology, and specifically to talk about the basal ganglia and one of the most relevant conditions, I think, to the basal ganglia, which is alpha-synuclein diseases. I have no disclosures or conflicts of interest related to this presentation. And just as an overview, I think I've always found it's most enjoyable and also most helpful to learning to discuss neuroanatomy within the context of a relevant clinical condition. And when I was asked to talk about this, I am the DBS neuropsychologist here at Northwestern, so I'm well versed in the basal ganglia and especially Parkinson's related disorders. But I also have a subset experience with Huntington's disease and expertise with that, in addition to general movement disorders. As I said, I was invited to talk about the basal ganglia, and I think the best way to learn about the basal ganglia is through the discussion of Parkinson's disease, as well as the deep brain stimulator, which directly targets the basal ganglia. So what better way than a disorder and its treatment to learn about this particular condition? If there's time, we'll talk about Lewy body dementia, which is closely associated, and multiple systems atrophy or REM behavior disorder, but I want to leave plenty of time for questions. So I erred on include more content, but I'll kind of gloss over a few things, but then I'll have slides if there's specific questions related to those pieces that I can always circle back to. We're going to talk briefly about kind of the basal ganglia overview, the basal ganglia's role with the thalamus, but especially the subthalamic nuclei, and then some of the brainstem neuroanatomy and frontal networks neuroanatomy. Again, I am glossing over some of the other common basal ganglia disorders like hypoxic and ischemic injury that can influence the basal ganglia. There's also autoimmune encephalitis that can influence the basal ganglia. Toxic etiologies, drug-induced etiologies, strokes, vascular-based injuries that can influence the basal ganglia, in addition to different pathologies. So there's tauopathies, TDP43 pathologies, genetic-based non-specific genes that can influence the basal ganglia that I'm not going to be talking about today, mainly because by far the most common is alpha-synuclein. And there's another important oversight, which I'm not including, is a discussion of Huntington's disease, which would be considered a genetic-based manifestation of a movement disorder that primarily influences the caudate. But I feel like once you master Parkinson's disease, all of these other etiologies and involvements with the basal ganglia just make so much more sense. And by far, Parkinson's disease is the most frequent, which is why I'm choosing to focus on this one. So Parkinson's disease and its associated pathologies and the basal ganglia. So first off, the way that we know a lot about the basal ganglia is through this little guy, these pathologies called Lewy bodies. So Dr. Fritz Jacob Heinrich Lewy, a good German, like my former name, Zieg is very much a German name, but I'm married and so now it's Cotton, much easier. He was a German neurologist who was a colleague of Dr. Alois Alzheimer, another name you should be familiar with. And he first described the pathology of paralysis agitans, also known as Parkinson's disease. And he was the first person to identify this inclusion body, later known as Lewy bodies, bearing his name, back in the early 1900s, around 1910, 1912. So now these inclusion bodies bear his name, and like all sort of good neurodegenerative diseases, essentially, if you recall, in the brain, there's constant moving pieces. There's buildup and breakdown of proteins that are necessary to help support neuronal functioning. And when a protein gets misfolded, it can no longer be broken down. And so it aggregates within the brain. And as it aggregates, it tends to aggregate around the neurons or disrupt neuronal transport, neuronal cell functioning. It can cause oxidative stress, mitochondrial dysfunction, synaptic dysfunction, and inhibition of the signals. And essentially what we get is certain pathologies have a predilection, is how I like to think of it, for certain brain regions. And alpha-synuclein's brain region of choice is very much the motor cortex, so the brainstem and the basal ganglia. And so alpha-synuclein generally first aggregates in the substantia nigra, which is up in the top right panel, in the anterior portion of the brainstem. And if you recall, the substantia nigra is responsible for the production of dopamine. And the basal ganglia uses dopamine to help initiate and control and sequence movements, in addition to a variety of supportive cognitive functioning. This is my favorite view of the basal ganglia because you get to see the whole image. So this piece wrapping around on the outside and then down around is the caudate. The piece on the inside is the putamen, and nestled even farther within and smaller is the globus pallidus. Here's an alternate view where we see the caudate on the top, and then you have the putamen, and then you have the globus pallidus nestled right in the middle. Another way I was told to remember the globus pallidus and the putamen was that the putamen is like the ice cream on top of the cone that is the globus pallidus. I never really resonated with that particular way to memorize or memorization strategy, I like to think of the caudate, putamen, and globus pallidus as nested within each other in smaller and smaller segments, and all share a supportive function. Now, importantly, to understand the basal ganglia's function and disruption of basal ganglia function, it's not important just to remember dopamine and the substantia nigra, but additionally acetylcholine, noradrenaline, and serotonin. Noradrenaline and serotonin also living within the brainstem in terms of the primary nuclei that produce them, and acetylcholine sitting in the basal forebrain, which sits just anterior to the basal ganglia. So all of these neurotransmitter systems have relevance to the basal ganglia. In addition, the role of the substantia nigra in brainstem aggregation as it relates to the descending pathways down the spinal cord, especially when it comes to impairing movement during sleep. So the sort of the classic REM behavior disorder, where sleep movements are no longer inhibited, and that's because of a difficulty here. I have some slides about that, and I'll talk about that if there's time. But again, I want to leave time to kind of talk more about the basal ganglia and what happens when things start to go awry. So what happens when alpha-synuclein starts to build up in the substantia nigra and stops the production of dopamine is that dopamine is no longer available to help supply the putamen. And the alpha-synuclein starts building up throughout the brainstem and moves up towards the basal ganglia itself. So you get sort of two hits happening, the substantia nigra degeneration and then additional degeneration moving upwards. And so you can see in the panel on the left, this is the putamen in Parkinson's disease across time. So in a healthy control, with the staining, you can see a large amount of cells that are still present in the putamen. And then in 1 year into Parkinson's disease, there's significant neuronal loss, following by 3 years, and by year 4, significant degeneration. A similar view can be seen through what's called a DAT scan, a dopamine transporter scan. And the DAT scan is actually a loflupane, which is the drug name, which is essentially a cocaine analog. So you take cocaine, the analog of it, you kind of reverse it around, and you mark it with a radioactive iodine, so that way when we inject it into individuals with presumed Parkinson's disease, we can see how the basal ganglia uptakes that specific drug. Because cocaine is very much like dopamine, it has a high predilection for the basal ganglia, so the caudate and the putamen within the basal ganglia structures. And you can see in panel A, early Parkinson's disease, where there's not a normal individual who has a reasonable degree of activation across bilaterally. And then in B, we have early Parkinson's disease, where you see a significant thinning of the activation with the DAT scan, to panel C, where we see late stage Parkinson's disease, where there's virtually minimal uptake of the cocaine analog, and i.e. their dopamine within the basal ganglia. Okay, now with Parkinson's disease, a DAT scan is very diagnostically indicative and reliable. For diffuse Lewy body disease, which I'll talk about in a little while, DAT scan is actually not that reliable in terms of diagnostic accuracy. But I want to focus a bit more on the basal ganglia for now. I would like everyone to pay attention to this, but not memorize this. There's another slide that I will say definitely commit to memory. This is not it. Namely because a lot of these pathways are hypothesized pathways, and if you ask any movement disorder neurologist, we don't have a good understanding of how the basal ganglia works together. And there's a shift more away from a frank inhibitory excitatory connection that's a little black and white in terms of its dichotomization, to more of, and I think across neuroscience, more of an oscillatory band frequency, where it's more about within networks, the pattern and sequencing and rate of firing across that that brain region, that specific neuroanatomical center, and how other brain regions then correlate or match frequencies or respond in frequency firings to other brain regions, versus this region connects with this region and it's either excitatory or inhibitory. However, with that said, I'll walk you through the historic direct versus indirect loops, with the caveat oscillatory beta bands are probably going to become more predominant in the literature. But this does have relevance at least to the hypothesized DBS mechanism. So I think it's easier if you like a schematic or a more technical version, please look at the model on the left. If you like more of a just quick visual version, please look at the panel on the right. So in theory, there's a direct loop, that's the one in green here, and an indirect loop, that's the one in red. A simple way to think about it is that the direct loop is the equivalent of putting your foot on the gas, and that's the one that dopamine initiates. So if you're driving a car, there's a few ways to move forward. You put your foot on the gas and that initiates, that prompts movement. That is from the frontal cortex through the direct loop into the putamen, and then through the thalamus, and some additional ways through the subthalamic nuclei, versus the indirect loop. The indirect loop is the equivalent of the brake. So in the car analogy, if you remove the brake, you also can increase movement, right? But if you inhibit, you're actually stopping movement. Now, the theory is, why do we need a direct that initiates movement and an indirect that stops movement? Is, well, if you think about it, we don't want to be moving all the time. And one of the main features of Parkinsonism is an inability to stop moving, right? A classic tremor, especially a pill rolling tremor. So you can see all the classic signs of Parkinsonism from problems with either the direct or indirect loops: difficulty initiating movement, so gait freezing, bradykinesia, slowed movements, tremors, uncontrollable tremors of hands, legs, occasionally mouth, head, neck. You can get yes, no, yes, yes, or no, no tremors. Essential tremor. We can talk about essential tremor, but movement disorder specialists will tell you we have even less knowledge or awareness of what causes the neuroanatomy of essential tremor, but other than the basal ganglia involvement in ways that we don't fully understand. So with this in mind, direct, like putting on the gas, indirect, like putting on the brake, both of which play vital roles in controlling movements, and in theory, result in the classic Parkinsonian symptoms. But this is very relevant, and I want to highlight the globus pallidus and the subthalamic nuclei, how closely they are connected, as well as both of their roles within the indirect circuit. So the globus pallidus is heavily involved in the indirect circuit, so is the subthalamic nuclei. We're going to come back to this when we talk about the DBS and why stimulating this helps in Parkinson's disease. Okay, so I also want to talk about the neuropsychiatric aspects, because the basal ganglia and its associated conditions never just produce motor symptoms. Well, I shouldn't say never, rarely just produce motor symptoms. Generally, they are combined with a host of cognitive, affective, and other psychiatric presentations and neurobehavioral symptoms. Now, an important thing to note is, regardless of the reason, alpha-synuclein disease, hypoxic ischemic injury, Huntington's disease, or an autoimmune encephalitis that targets the basal ganglia. I've actually seen a few cases like that. The symptoms will be the same. The neuroanatomical real estate is always the neuroanatomical real estate, regardless of what the etiology is. So all of these symptoms apply regardless of the etiology. So keep in mind that for Parkinson's disease and basal ganglia disruption, you're going to usually get treatment with dopaminergic medicines, which create in and of themselves impulse control disorders and psychosis. And usually there's multi-morbid, sort of high levels of intra and inter-individual variability in presentations of the neuropsychiatric aspects of a condition. For like all neurologic conditions, the way one person presents with the same set of disorder or same set of circumstances might be very different case by case. But I do think it's helpful to always consider each of the possible cognitive and neuropsychiatric elements importantly, so that when you see a case who has basal ganglia involvement, you are assessing for each and every single one of these pieces, regardless of the etiology, because you know if this brain region is involved, this cognitive or neuropsychiatric aspect might come into play. Now, my next slide. This is the slide I would commit to memory when it comes to basal ganglia systems as a neuropsychologist. This is the one I use most often clinically for my clinical conceptualization of cases and for my explanation to the neurosurgery team when it comes to making DBS recommendations. So if we think about the basal ganglia, there can be a primary mesostriatal pathway dysfunction. This is, so striatum, I'm sure you've heard, if I go back to my brain, so the striatum just refers to this area here within the internal capsule between the basal ganglia and the thalamus, and also between the caudate and the globus pallidus and putamen. So the mesostriatal pathway is primarily motor driven, sensory motor, versus the mesocortical pathway and mesolimbic. And here's where the cognitive and neuropsychiatric features come in. So mesocortical is the connection between the basal ganglia, the caudate and the putamen, and the dorsolateral prefrontal cortex and executive functioning. And then the mesolimbic, this ventromedial striatum and the nucleus accumbens, and the anterior cingulate. Anytime you're hearing anterior cingulate, you should be thinking emotion. Helen Mayberg's work with the subgeniculate cingulate absolutely should be thinking depression and associated disorders and impulse control disorders. So the anterior cingulate is the gateway to the frontal lobes and the reward networks of the inferior frontal lobes. And so mesolimbic needs to be on your differential for basal ganglia dysfunction. Here were 3 cases. I love this because as I was making these slides, I literally saw 3 cases within the same week who presented in each of these ways that just happened to match up the pathology, but I think really highlights the variation that can be seen and drives home each of these basal ganglia related loops within the striatum, the subthalamic nuclei, and interactions with the rest of the cortex, and the role of dopamine in them. So for example, one of them was a 72-year-old woman who had Parkinson's disease. She had frequent bradykinesia and primary psychomotor and processing speed slowing. She was not otherwise cognitively impaired. She didn't have emotional disturbance. She was just exceptionally slow and had primary motor symptoms. So she would be classified in the mesostriatal pathway with kind of a classic bradykinesia. And if given too much dopamine medicine, we'll have dyskinesias. And dyskinesias, for those of you who aren't aware, dyskinesia is what happens when there's too much dopamine and people can't stop their motor symptoms anymore. So they're no longer slowed and immobile, insufficient dopamine. When they're given a dopamine treatment like carbidopa, levodopa, the standard treatment for Parkinsonism, what happens at higher and higher doses is the basal ganglia then gets overstimulated and they move. They move, they roll their heads. I've literally had people fall off of their chair. They can't sit in their chair. Dyskinesias are exceptionally bothersome. And so there's this Parkinson's symptoms of tremors or not being able to move and slowness, to the other end of the extreme with treatments where they're moving and shaking so much because their basal ganglia is so activated and there's so much dopamine that that's almost as impairing as not being able to move, which is one of the main reasons for pursuing a DBS evaluation. And this nice 72-year-old lady very much exemplified this. Now, alternatively, there was a 48-year-old man I saw with Parkinson's disease who, as soon as he started dopamine medicine, developed an impulse control disorder related to sex and spending. And he described the most fascinating depression experience. He reported a depression experience of a little bit of depression earlier on. And he described at that time, earlier in his adulthood, like a classic depression. I just felt down and blue and, like I was self-critical and hard about myself about something that happened in his life. But he was very clear with Parkinson's disease, this was not the same depression. He said, it's not a low mood. He's like, I just don't care about anything. Like, what's the point? It's just all an empty abyss. And oh my gosh, I'd never heard such a marked description of apathy or a mesolimbic involvement of an extreme depressive experience that was not just, oh, I'm just a little down or blue, an empty abyss, right? Like that is just the epitome of apathy, with also, when he was given dopamine, directly resulting in an impulse control disorder, right? So he was clearly mesolimbic involvement in addition to his sensory motor PD symptoms, versus a nice 65-year-old man that I saw who had no impulse control issues. He didn't have mood issues, but what he did have on cognitive testing was he could not engage in quick mental flexibility. He could only take in a limited amount of information at a time, that kind of typical flat encoding curve that we see in our neuropsych profiles across learning trials. And he couldn't do Charles B very easily. And he was classic mesocortical, right? Where the dorsolateral prefrontal cortex was just not strong in him anymore. And so we got primary executive dysfunction for him as a part of his clinical presentation. So each of them Parkinson's disease, each with heavy basal ganglia dysfunction. They all had documented Parkinson's disease, but with very different presentations, but ones that I think match mesostriatal versus mesocortical versus mesolimbic pathways. So if anything, take away this slide versus the other one of here's this indirect connection, which loops on this, which loops on that. I think this is a more helpful way, but if you memorize the other one, good for you. My blessings to you and to your hippocampus and its ability to take in and memorize. But let's talk about how we treat the basal ganglia in Parkinson's disease, because I think it helps further drive home the role of the basal ganglia and what we need to consider as neuropsychologists when we consider basal ganglia disorders, particularly dementia as it relates to basal ganglia disorders. So why do we use the DBS in a Parkinson's disease? And what is the DBS? So DBS is for deep brain stimulator. And the typical age range and disease duration for DBS placement is about 10 years into the Parkinson's disease course. By this time, the initial benefits from dopamine medicine have worn off as the disease progresses. And usually there's very bothersome dyskinesias, the negative side effects of excess dopamine now coursing through their basal ganglia, persistent or advanced Parkinson's symptoms at that point. They might have what's called frequent offs, where the basal ganglia just stops responding to dopamine. They can take their normal dose of dopamine medicine and their brain just acts like nothing happened. It doesn't register. It's like a missed dose phenomenon or a rapid off that can happen. And generally also the window of the on time that their symptoms are actually responsive to dopamine becomes smaller and smaller. So out of a 4-hour dose window, they might now only have 2 hours of good time. So on either end, there's an hour on and an hour off. And their poor medication schedules become so complex. They usually are taking 3 or 4 different dopamine medicines, which raises the likelihood for neuropsychiatric and cognitive symptoms or impulse control issues. Their dose scheduling is insane. 2 hours take 4 of this. At 4 hours, take this. And then every 1 hour, take this one. And it becomes so complex that it's just really difficult to manage. And so the stimulator is intended to replace the medicine. And as you can see, the electrode either gets implanted, if you look in the panel all the way to the right, into specifically the globus pallidus or the subthalamic nuclei. The subthalamic nuclei is now more predominant, but both are equally effective at controlling Parkinson's symptoms. The subthalamic nuclei is slightly better for the control of tremor, but the globus pallidus is slightly better for dystonia, the rigidity, the muscles getting stuck and the movements getting stuck. Generally, you can reduce the dopamine medications a bit more with stimulating the subthalamic nuclei than with the globus pallidus, but it's specific to each particular person's presentation of Parkinson's symptoms. More dystonia, more tremor, more freezing, more gait instability, in terms of which target might be selected. Generally, a bilateral, both hemisphere approach is achieved or is the goal because it's a neurodegenerative condition. It builds up on both sides of the brain. Generally, it does start more on one side, but because by the time 10 years in, general involvement of both sides is pretty common, we implant individuals in both sides. Now, interestingly, with a DDS, we've become much more advanced when it comes to the electrode itself. So if you look down at the bottom of this picture here and you see the electrode, each of those little coils is a stimulation piece. And now we can sort of direct. It used to be that you stuck it in and it could just send off one signal in one direction. And now there's all sorts of device parameters. We've come a long way. So you can now select, do you want the stimulation to come out of this one or these top three? And do you want it to go left? Do you want it to go right? Do you want it to go up? Do you want it to go down? And so you can really change the angle that you're stimulating to try and best capture the neuroanatomical target. In addition, it's usually done in a two-staged approach where we implant one side and then we implant the other a month later, because it is shown that that's associated with better outcomes. If you implant both at the same time, generally people have more cognitive side effects shortly after and a higher adverse events risk profile. So usually one side is implanted at a time, the first side and the first lead, and then they it's not delicate if you've ever seen it done. They take the equivalent of what looks like a fire poker and sort of rod it and ram it down someone's neck cavity to create space for the electrode. And then they put the battery in a person's chest pocket, their little chest cavity here. We all kind of have a little fat pocket there, some more than others. And that's where the battery is implanted and where the leads are placed. We now have rechargeable batteries. Individuals used to have to get their device recharged frequently or batteries replaced frequently, and now we can recharge it, which is great. And then the procedure lastly is done awake so that an individual, the electrode activation or testing the electrode placement is done awake. So a person's brought in under sedation, then woken up, and you're testing the placement of the electrodes to be sure that you have it in the right place, and then they're put back to sleep for especially the channeling down the neck cavity, which is not pleasant to watch. I would not want to be awake for that, and for the rest of the procedure. Interestingly, as I was talking about kind of the oscillatory bands, and at first I was a young neuropsychology student and I thought the neurosurgeons were potentially just messing with me. But these electrodes can be hooked up to an audio output so that you can hear these signals from the electrodes, a lot like an EMG, like the physiatrists use to hear the sounds of muscles. And so essentially when you put your electrode down through the different brain regions, it actually produces a different sound at each stage. And when you get to, I forget if it's the subthalamic nucleus or the globus pallidus, I think it's the subthalamic. The neurosurgeons know that they're there because it sounds like a light rain, like rain on a tin roof, like just this light tap, 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 tap sound. And that's how they know they're in the right place because of the firing frequency. Additionally, if you hear it as it's going down, you also hear these little squeaks. It's like a little squeak. And they had told me that that is the sound of a neuron dying. And I again was like, are they pulling my leg? But I asked my husband, who's a neuroscientist and who does, he's also a physiatrist and he does EMGs. And he's like, oh, absolutely. You kill neurons when you put an electrode through there and they do give off a death squeal. which is a known phenomenon. So keep that in mind with the oscillatory band frequencies, as well as the fact that occasionally some neurons do get damaged when we're putting in these electrodes, which is why it's not without risk. Now, the electrodes and the implants continue to work as long as they're activated and there's battery life. But generally so you have 10 years of medicine, then you get an implant that stimulates and you take away the medicine. And then after about another 5 or 10 years, you have to add medicines back on. But the time that it's on, it's still offering an effect. So again, by disease stage 20 to 30 years, you're still able to then get the benefit of adding medicines back on, which is great. Now back to the cognitive impact of DBS and Parkinson's disease. And this is where Parkinson's disease dementia can come into play. So there's kind of 3 different outcomes when I think about DBS and Parkinson's: green light, yellow light, and red light. Now we know from very few early studies that if we implant someone with Parkinson's disease dementia, 2 bad things happen. Their motor symptoms don't respond, and we make their dementia worse. That's pretty bad, and we don't want to do that. And that happens when there's evidence of extrastriatal impairment or a more diffuse pathology or a more advanced Parkinsonism that's associated with the dementia. So we do not implant people with dementia, active dementia. We just don't. But how do we determine who's not demented? So if we see someone who has no or minimal or mild cognitive or neurobehavioral changes that are consistent with a typical Parkinson's disease duration, about 5 or 10 years, who has that mild executive dysfunction that we saw with that lovely gentleman who had primary mesocortical dysfunction, without retentive memory impairment, without impairment in his daily functioning or ADLs, or someone who has a totally clean cognitive profile. Those individuals get the intended motor benefit and don't have any cognitive decline. But as you know, as a neuropsychologist, not everything fits nicely into those boxes. And you're going to occasionally get some of these in between cases. And this is where the mild cognitive impairment is greater than what we would expect for Parkinson's disease and their duration. 2, 3 years into Parkinson's disease, they're not responding to medicine, so they're considering DBS, but they're showing much more concerning cognitive impairment, or they're showing more severe executive dysfunction or possible extrastriatal pathology, so dysfunction outside of the basal ganglia, like language dysfunction, primary retentive memory impairment, visual spatial dysfunction, hallucinations that are not medication related. Then we might consider 2 things. You can either slow down and retest in a year to see if it's a progressive condition. If we implant at that point, we might accelerate that decline. Or you can speed through at some risk and know that, like, if you speed through a yellow light, something bad might happen, which is generally not recommended. But in some cases, we also just don't get a clear picture. What if we got bad data because someone's not a native English speaker and that's why their verbal memory scores were impaired? And those are all pieces to consider with cognitive profiles in DBS. Now, what happens after we actually implant the DBS? So if they get a green light and they're not demented and we implant them, DBS is hypothesized, again, movement disorder docs will say, they're still not entirely sure why, but we essentially inhibit the inhibitor. So if you remember, the indirect loop is thought to be the brake. And if you inhibit the brake, it's the equivalent of lifting off the brake, which means we increase movement. You take off the brake, it increases movement and makes movement easier. That's how it's hypothesized to work. However, with DBS, even in non-demented DBS, you can get some significant depression because you're withdrawing dopamine, and a rapid reduction of dopamine can cause depression. You can get mania because maybe they're still taking high levels of dopamine medicines while their stimulation's being ramped up, or from just continuous stimulation, which can sort of mimic manic symptoms. You can get psychosis with that stimulation, but generally that improves with medication reduction. There are some experimental gene therapies with certain enzymes that we could do as dopamine precursors. I was involved in 1 or 2 of those clinical trials, but we had to end them because they weren't very effective. So I don't think that's going to be an up-and-coming treatment. So we have about 15 minutes left, and I want to leave plenty of time for questions or additional topics. So I'm happy to discuss any of the additional remaining items, either Parkinson's disease dementia, Lewy body dementia, or multiple systems atrophy, but I want to be sure to leave time for questions and what people want to hear about. So I'm going to stop there momentarily and open it up for questions at this point, if that's allowed. I thought I was supposed to stop at about 1/4 to leave time. I'm not hearing no, and I'm not seeing any questions. So
It will be fine if you can go.
It's fine to keep going. I'm personally interested in several of the topics that you have here. But we can send you a message in the chat if we do have any questions that come up.
okay, perfect, great. So let's see, go through all the sections. Perfect. Okay, so I want to talk about Parkinson's disease dementia and Lewy body dementia. So I'm going to go by REM behavior disorder. So let's talk about alpha-synuclein and Parkinson's. Oh, let me close my chat. Parkinson's disease dementia. So cognitive impairment is frequent in Parkinson's disease. In any alpha-synuclein disease, it's not uncommon to have cognitive changes. And the cognitive changes are often extremely heterogeneous, but usually executive. And that can be subtle changes and mild to full-blown severe deficits, as in Parkinson's disease dementia. Now, the changes in Parkinson's disease are generally thought to reflect both structural changes in the neuroanatomy, the basal ganglia, and its cortical connections, especially the dorsolateral prefrontal cortex, in addition to a neurochemical storm from changes in dopamine, cholinergic, noradrenergic, and serotonergic neurotransmitter systems, and then additional buildup of the pathology in various additional brain regions, as well as the fact that there's some connection between Lewy body pathology and coexistent Alzheimer's pathology, amyloid and tau, and cerebrovascular disease. So it is rarely clean. Oops, go ahead, advance. There we go, okay. Most individuals do have some form of mild cognitive impairment in Parkinson's disease, and by 10 years, a fair amount will develop Parkinson's disease dementia. And after about 20 years, about 80% develop Parkinson's disease dementia. I may be a little biased because the DBS sample that I see, it's probably less than 50% who have Parkinson's disease dementia. But generally, with Parkinson's disease, you actually want earlier age of onset and tremor predominance. Those factors are associated with the best cognitive outcomes. Someone onsets in their late 50s, early 60s, as in their first signs tremor, they're likely to have the best, most clean cognitive course. The pathology stays well behaved right in the brainstem and basal ganglia systems, just interfering with the dopamine-mediated executive dysfunction. The later the age of onset, 70s, late 70s, non-tremor predominant, like gait primary, the worse the cognitive course, mainly because there's additional pathologies by that age. By age 70, the risk factors for comorbid Alzheimer's pathology and vascular pathology, as well as less behaved alpha-synuclein, that alpha-synuclein might build up in other brain regions outside the brainstem and basal ganglia, which creates a more unstable cognitive picture, is more common in later age ranges. And additionally, DBS is not without some cognitive risk, and some individuals can experience changes in their thinking abilities after DBS. Here's the kicker though. Think of Parkinson's disease dementia as a dual syndrome. So initially, there is this greater frontal striatal dopamine modulated executive dysfunction. Think dorsolateral prefrontal cortex dorsolateral prefrontal cortex, prefrontal cortex with attention, working memory, planning, response inhibition. That's generally the earliest and first cognitive symptom. Followed by, as the alpha-synuclein builds up, you get this greater posterior cortical degeneration and temporal degeneration, which includes more memory, language, and visual spatial impairment, which then leads to dementia. So initially non-demented, usually executive dysfunction, and by the time the pathology is spread out, this leads to a dementia picture. Now, interestingly, Parkinson's disease dementia presents a lot like Lewy body disorder, and we'll talk about that. Again, Only 38% of patients with Parkinson's disease dementia had pure exclusive Lewy body pathology. Over half had combined Alzheimer's and Lewy body pathology, and also vascular changes. So there's a huge correlation and it's not clean. But I want to take the time to talk about whether or not Parkinson's disease dementia and diffuse Lewy body disease are the same or distinct. And this has been debated based on the 1-year rule. So if you learned, like I did back in grad school, Parkinson's disease is when there's just motor symptoms to start. Lewy body disease is when there's motor symptoms and within 1 year, cognitive or neuropsychiatric change. However, what happens when a person with Parkinsonism also has the typical frontal executive changes that we all know happen with Parkinson's disease that are agreed to not be diffuse Lewy body disorder? Or when someone with motor symptoms by year 2 or year 3 has frank retentive memory impairment, florid hallucinations, fluctuating cognitive status, and very much takes a more rapidly declining cognitive course and clearly looks like a diffuse Lewy body person. So there's debate about whether or not this 1-year rule is accurate. Again, it's sort of like an arbitrary criteria to describe different phenotypes. One in which the alpha-synuclein sort of adheres very nicely to the basal ganglia and brainstem in Parkinson's disease and takes this slow course where it builds up very gradually. And ultimately, after 20 years, you get a little leak out, versus in diffuse Lewy body disease, where the same exact pathology still has a predilection for the basal ganglia, but is also building up wherever else it wants within the brain. Predilection for probably amyloid beta, also accumulative hippocampal, temporal lobes, and wider out in the posterior regions of the brain with worse visual spatial functioning. We can review the McKeith criteria for diffuse Lewy body disorder with fluctuation cognition, hallucinations, and one or more features of Parkinsonism, but not full Parkinsonism. And then probable versus probable. I love this article. Are dementia with Lewy bodies and Parkinson's dementia the same disease? I tend to think of it like a spectrum, like this article proposed, with one end, and this is the panel on the left here, on one end, you sort of have incidental Lewy body disease. There's a buildup of the pathology with no diffuse or no clinical syndrome. So there's not motor symptoms, there's not cognitive symptoms, it's just there. And then you get the buildup of Lewy body disease in non-demented Parkinsonism, where that pathology sticks in the striatum, right, within the brainstem and within the basal ganglia. And then you get Parkinson's disease dementia, primary Parkinson's, with a bit of buildup after a long disease course, 20 years into the disease, where now the pathology is expanded out a little, versus diffuse Lewy body, where same pathology, slight predilection for the basal ganglia and brainstem still, but much more robust buildup all throughout the brain, versus on the extreme end, diffuse Lewy body, little buildup in the basal ganglia, much more buildup everywhere else, with comorbid Alzheimer's disease impacting the middle temporal lobe structures, which is a really bad cognitive impairment and produces generally a fairly rapid and robust decline. So you get someone who thinks they're getting diagnosed with Parkinsonism, and they're going to be like Michael J. Fox and just have a tremor 20 years in. And by year 2 or 3, they're in a nursing home because their cognition's completely impaired. They have motor symptoms, they have hallucinations, and they have retentive memory impairment. It can be really disabling. Now, the other piece is that likely there's probably a synergistic or additive triggering effect between these protein pathologies. So increasing levels of AD pathology likely increase the burden of alpha-synuclein pathology. And so there's an overlap between the diffuse Lewy body and AD pathology, and there's likely a shared genetic risk factor as the alpha-synuclein allele also correlates with Lewy body buildup in addition to amyloid beta and tauopathies. So it's not just one of those alone, but rather the mixed pathologies that likely contributes to the presentations that we see. And again, Parkinson's disease generally seems to have a slightly earlier onset, late 50s, early 60s. Diffuse Lewy body disease generally happens a bit later, closer to late 60s, early 70s, with generally phenotypically distinct sort of alpha-synuclein aggregation patterns and likelihood of timing and overlap with amyloid beta related pathologies, in addition to vascular impairment. Now, the last thing I'll touch on before then I give back to questions is multiple systems atrophy, which is essentially a buildup of alpha-synuclein lower down in the brainstem. So specifically, that you get the hot cross bun sign, specifically in the pons. So rather than building up in the substantia nigra, you see a buildup lower down in the pons. And this creates this classic T2 flare here. And this creates more autonomic dysfunction, more cerebellar dysfunction, and cortical spinal dysfunction in patients. And it is another way that the alpha-synuclein can interact. But you might also still get some classic Parkinson's symptoms with that. Now, the last thing before I turn it over to questions, sorry for the fast scrolling, guys, is the role of REM behavior disorder. And so REM behavior disorder is it is a very good marker for alpha-synuclein disease. 80% of people with alpha-synuclein disease will have had a REM behavior disorder prodrome. And that's because as alpha-synuclein really chooses to build up in the brainstem and just above or just below the basal ganglia here, we get a disruption in the descending motor pathways that stop movement during REM sleep. And as these neurons start to degenerate, those signals start to become weaker or less reliably initiated. And so you get an acting out of movements during REM sleep. REM sleep in individuals. So acting out your dreams, punching, kicking, yelling, because if you recall in REM sleep, the brain and the cortex are actually very active. And in most individuals, we stop, we inhibit the acting out and the actions within our body. But in people with alpha-synuclein buildup, they lose that inhibition. So REM behavior disorder, highly related to alpha-synuclein, and you should be very much keeping an eye out for basal ganglia related dysfunction and movement disorders in individuals who present with the REM behavior disorders, especially if they're in their 50s. And again, the same thing, whether or not it's an alpha-synucleinopathy or a hypoxic ischemic injury or a genetic condition or a toxic metabolic factor that creates basal ganglia dysfunction, don't let these symptoms lie. So for example, I saw a case of an autoimmune encephalitis, but they were doubting that diagnosis because he presented more like a Parkinson's patient. But I said, he looks Parkinsonian, he's slightly dysexecutive, he has the apathy, he has all of these sort of basal ganglia associated motor, cognitive, psychiatric features. And it turns out his autoimmune encephalitis pathology just happened to have a predilection for the basal ganglia. And so he presented with a primary autoimmune encephalitis basal ganglia related disorder. So keep all that in mind. Okay, I'm going to turn it over for questions now. And go back. And I'm going to go to the chat to see if there are any. Okay. So here's my questions. Is a history of ADHD a treatment consideration? How might that impact treatment? Thinking as limbic inhibition issues. Yeah, so that's a great question. At this point, a lot of the individuals currently seen for Parkinson's or DBS, they were of the generation before ADHD really became known. So you're relying pretty much exclusively on self-reports there. And usually, like with anything, if there was a premorbid weakness, it then becomes exacerbated when there's dysfunction, and they might have, depending on their course, more of an inattentive versus hyperactive type. And oftentimes that can come out more. It makes it hard, though, to differentiate how much of this is pre-existing ADHD exacerbated by current basal ganglia dysregulation versus newer onset basal ganglia dysregulation that we need to really be concerned about, where it's indicative of a more severe disease course, if that makes sense. It's very tricky, and generally monitoring them closely for side effects is really important, which is why you want to consider cognitive and neuropsychiatric features. Okay, I'm going to assessing for REM behavior disorder, I come across people who say that they move in sleep, but they associate this with PTSD. In discriminating movements related to trauma, is this a thing? And movements related to REM behavior disorder, is the best thing just to recommend a sleep study? Great questions. I would question in what other neurologic context, and any other neuropsychiatric features, neurologic conditions. So age, first off. If it is a 20-year-old who was just sexually assaulted, my differential for an alpha-synuclein boding REM behavior disorder is much lower. In a 50 to 60-year-old person, my suspicions would be higher. A 50 to 60-year-old person who had a recent fall because their foot caught somewhere and they just couldn't catch themselves, my suspicion would go even higher. So you could always have them see a neurologist to assess if there's any discrete neurologic impairment related to movements, or evidence of primary neurologic dysfunction in addition to a sleep study. So age and any additional symptoms or indicators, and when in doubt, have them see a neurologist, and they can start with a general neurologist to ensure that there's no additional concern with that. But people can have REM behavior disorder up to 20 years before Parkinson's disease.
Thank you, Dr. Cotton. We are running out of time, and thank you for the wonderful talk. Are there any additional thoughts that you may have before we conclude?
Just checking. I think we covered REM behavior disorder. Suggestions for studying, aspiring, furthering their knowledge in neuroanatomy. If you can get to a brain dissection, do. And if you have behavioral neurologists, or if you can round with neurologists, or if you can round with PM&R doctors on their rehabilitation units, especially neurorehabilitation units, stroke, TBI, brain tumors, etc., do. Those are excellent learning opportunities. I think that's pretty much it.
Okay, thank you all for coming. I just want to remind you that we will have another talk on July 17th with Dr. Georgina Moreno, and she will be discussing emotions in the amygdala. Sounds very exciting, and I hope to see all of you there. Thank you again, Dr. Cotton. This was very informative, and we appreciate your time and your expertise.